Afternoon, everyone. I'm very excited to be in Namibia for my first time. It's been very pleasant so far. My name is Kamban Hirasen, and the title of my talk is The Economic Recovery Among Patients Following Drug-Sensitive TB Treatment in Johannesburg, South Africa. I'll be presenting this work on behalf of my list of co-authors below the title, as well as on behalf of the larger TB sequel study team. I have no conflicts of interest, but just a quick disclosure, this is not going to be a clinical presentation, and I know a lot of you are very clinical minded, so hopefully you are interested in this work. So based on the title of my talk, you may first be wondering why a focus on economics. And for decades, TB research focused mainly on the evaluation of clinical outcomes along the care cascade, so looking at prevention, treatment, diagnostics, and specifically within treatment, looking at rates of cured, complete, failed, loss to follow-up, and death. And considering the relatively high mortality, specifically in South Africa, which peaked in 2006 at 77,000 deaths that year, or 13% of all deaths in South Africa that year, a clinical focus was the right approach. However, from the early 2000s, we had access to shorter and better tolerated drug-sensitive regimens. And then from the early 2010s, there was the introduction of rapid diagnostic tests such as GeneXpert, followed by more efficient treatment models such as the decentralization of care. And so with these and other advancements, clinical outcomes, while not perfect, are better than ever. However, effective healthcare programs doesn't necessarily equate to effective healthcare. And we know that in most public settings, TB treatment is provided free of charge to patients. Although, while seeking care for a formal diagnosis and completing the treatment that follows, 32 to 83% of patients or households incur catastrophic costs, which is basically the total cost of seeking care for TB exceeding 20% of the pre-TB household income as defined by the WHO. So there's a significant economic impact of the disease. The second question you may be asking is why the period following treatment completion, and I think Dr. Katsagira explained that fairly well. And over the last decade or two, there's been a shift into looking at the post-TB treatment phase. And up until then, there's the general consensus was that once a patient is cured, they sort of return to the health state that they were in prior to diagnosis. And we know that that's not necessarily true. And so Taylor and colleagues have shown that 60% of patients have an abnormal spirometry reading following successful treatment. Romanowski and colleagues show that patients have an extra 12 visits relating to respiratory illness following, again, successful TB treatment. And then lastly, Meji and colleagues show that 19% of patients experience declines in lung function a year after completing treatment. And that is a promising trend because we see that there's an increased focus and this upward trend in post-TB related research. Although if you have a deep dive into these publications, not many of them look at the socioeconomic impact or the economic impact to patients and their households. And so we wanted to describe changes in economic indicators, which included employment, working hours, income, coping strategies, and self-perceived financial impact of TB from treatment initiation to 18 months after completing treatment. So we did this by conducting a socioeconomic sub-study nested within TB sequel, which is a prospective cohort study designed to understand the risk factors affecting long-term pulmonary function in people with drug-sensitive TB. The study was conducted in Johannesburg, South Africa, and we looked exclusively at adult populations initiating drug-sensitive treatment. They also had to have at least one sputum sample tested positive for TB by smear or expert and living within the research catchment area during the study period. We utilized the World Health Organization Patient Cost Survey and adapted it for longitudinal implementation. And thereafter, we surveyed patients at treatment initiation, which we defined as month 0, treatment completion, month 6, 6 months post-treatment completion, which was 12 months after initiation, and then 18 months post-completion, which was month 24. And here we present the socioeconomic data for patients completing the surveys, firstly at respective time points, although I'm not going to focus on that, and then specifically a complete case analysis for a subset of patients completing surveys at all the time points. And just a quick side note, this is still very preliminary results, and we'll probably take a deeper dive in the coming months. I wanted to include this slide just as a resource for anyone interested in costing methodology or economic evaluations. This is a very useful tool by the WHO, which outlines the methodology for patient costing, what types of data that's being collected, at what time points, how to extrapolate the data, and come up with a comprehensive patient cost estimate. In terms of the results, a very quick summary. So we had 324 adults in total. Most of them were male with a median age of 37 years. Again, most of them were sputum smear positive at baseline, and considering it was South Africa, we also have a very high co-infection rate with HIV. And about a third of patients identified themselves as the main income earner of their household. So these are the main results looking at the patient's economic recovery across time. And we have 3 main domains here. I'll start with the labor-related activities. And we can see that employment to begin with is fairly low at 52%. At 6 months, it declines into the 40s and then declines more 6 months after successfully completing treatment down to about 24%, if I can see right. And then only at month 24 does employment return to something that resembles baseline, although not quite, still a few percentage points below. Among those who were employed, working hours remained relatively stable at about 8 hours a day, and personal monthly income in South African rands, which I think is a 1-to-1 ratio to the Namibian dollar, started off at about 2,400 rands at month 0, increased slightly towards the end of treatment. And again, there's something about that 6 months after completing treatment where things decline further and then rebound 24 months after initiating treatment. In terms of coping strategies, so this is when patients use savings, borrow money, or sell assets, including livestock, to fund their TB care seeking. And we'd expect these to be higher at baseline whilst they seek a diagnosis, and then decline as they complete treatment, which is what we found. Although there was that slight uptick in the use of savings at month 24 for just a very small number of people, and we're not sure why that is. It might be related to potentially a new episode of TB. And then in terms of the self-perceived financial impact of TB, so a few people report serious or very serious self-perceived impact of TB at month 0, and then as expected, this declines as treatment is completed and then into the post-TB treatment phase as well. So there were a few limitations to this work. So the first one being representativeness. The study sites were limited to only one urban South African city, namely Johannesburg, and patient costs and socioeconomic recovery presented here may not reflect more rural South African populations who have lower levels of employment opportunities and associated personal and household income. We have also a very limited sample size of 130 patients in the complete case analysis, and selection bias is obviously a big one. So both the crude and complete case analyses included patients with sustained engagement in care, and these patients probably are in better health and better economic standing than those with poorer or unfavorable clinical outcomes, so those who were lost to follow-up, potentially died or failed treatment, and assessing the economic recovery within this subgroup, specifically within those who failed or may have been lost to follow-up, possibly through telephonic interviews or home visits, may reveal limited economic recovery. And then again, this was exclusively amongst drug-sensitive TB populations, and we know that DR TB populations have poorer clinical outcomes, more severe disease, and their economic recovery could also be much worse. So to conclude, in this urban South African population, socioeconomic indicators such as employment and income declined early in treatment and remained persistently low even 6 months after completing treatment. However, a year and a half after completing treatment, employment and income stabilized to levels that resemble baseline. And just a note, social protection made available from treatment initiation may assist these vulnerable patients to facilitate, firstly, improved clinical TB outcomes, improved general respiratory health and recovery, and then dampen the negative socioeconomic consequences of the disease. I'd like to thank our funders, partners, and the conference organizers. Thank you.